Assessment, take 2. The first assessment that I did was interrupted by a phone call, and it was supposed to be continuous, and it also ran over an hour. I'm going to post both of these, but this one I'm going to try to really keep it within the 20 to 30 minute time frame. We have an alarm set for 15 minutes, and we're going to start now. So I'm Shannon. If this was a regular assessment, I would come into the patient's room, I would close the door or shut the curtain to give us privacy. I would introduce myself to the patient. I'm Shannon, I'm going to be your nurse today.
Hi.
What's your name?
Stanley.
Okay. Can you verify your first name only and your date of birth?
Stanley 1/18/82.
Perfect. And again, quarantine, I don't have the proper equipment, so I would obtain his vitals first before doing anything else, but I would also let him know and ask permission. Is it okay if I get your vitals and do an examination on you today?
Yes.
Okay. So I would collect his blood pressure with either a nurse on a stick or a manual blood pressure cuff placed over his bare upper arm, and have the arrow pointing to his artery here. And if it was manual, I would place my stethoscope. Nurse on a stick will do it for me. I would check his temperature, respirations, heart rate, pulse ox, and verbally obtain a pain scale. On a scale from 1 to 10, what is your pain level?
1.
A 1, okay. Do you have any chest pain, palpitations, or dizziness right now?
No.
Okay. We already know his health history, so I'm comfortable just going into his examination. But first, I'm going to wash my hands. And in a regular setting, I could wash my hands and either just, as long as the patient's comfortable with just my bare hands, or I could put gloves on. I'm going to do a barehanded. So infection control, I've verified the patient's name and date of birth. He has no medication allergies. So we're going to get started. We're going to start with the inspection, because the order is inspect, palpate, percuss, and then auscultate. So we're going to start with inspection of the head, and we're going to try to keep it as head to toe as possible. So inspection of his head, I can tell that it's normal for his body type. His eyes appear to be lined up. His pupils are normal and equal, which is negative for strabismus and negative for anoscoria. I can tell that he has equal distribution of hair with his goatee and his eyebrows and eyelashes. I don't see any patches missing anywhere. I don't see any lesions. His skin looks healthy. He looks hydrated. I don't notice any dryness, lesions, fungal, cuts, open wounds. His skin tone, he's Native American. It's appropriate for him. I can do a light scalp examination where I'm lightly but also palpating. If anywhere I touch is tender, can you let me know? But as I'm palpating, I'm looking for lice, open wounds, lesions. I'm palpating not only for tenderness, but for masses and lumps. And I'm not finding anything notable here. I do notice his skin. There's an abrasion over here on the side of his neck that is healing, almost gone. So he denies tenderness here. His hair is equally distributed, no alopecia, no abnormalities whatsoever in his scalp. And so we can start the inspection process of him in general. His breathing is easy. I'm not noticing any abdominal breathing or extra accessory muscle breathing. He's unlabored. He's not out of breath. His speech is normal. I'm not noticing any facial droop. His lips look healthy, slightly dry but healthy. They're pink. His nose is midline symmetrical with his face. I don't see any acute deviations. No droops. When he answers my questions, I don't notice any slurs or interruptions with his speech. His eyes, just from inspecting, close your eye. His eyelids are healthy. I don't notice any swelling, any exudate. Can you close them really tight? Thank you. Open. And just from examination, his sclera is white, not yellow, which would indicate jaundice. His conjunctiva is pink, not red, so no inflammation, no swelling. His pupils are clear, equal in size. And I'm just going to palpate here quickly. Any pressure? Any pain?
No.
Any pain here?
No.
Any pain here?
No.
Have you noticed any runny nose, any headaches? Okay, and then we'll palpate here. So we're not only palpating his maxillary and frontal sinuses for inflammation and infection, we're palpating the 3 areas to check his facial nerve for sensation. I'm going to have you smile, frown, blow out your cheeks. Okay, so again, cranial nerve examination, facial nerve intact, and we're going to do his His ears, we'll check them. I have my makeshift otoscope here. So while I'm checking his, I would take this. You don't go into the ear canal, you just lightly go in. So as I'm about to start checking his ears, which I can tell are not red, inflamed, I don't see any drainage. Have you had any pain in either ear? Have you
No.
noticed any excessive wax or drainage?
No.
Okay. And I'm just going to lightly palpate from the top all the way down to the bottom to the mastoid. Any pain when I'm doing this?
No.
Any pain when I'm doing this on this side?
No.
Okay. He's very symmetrical. I'm not noticing any abnormalities. So if this were a real otoscope and I was really checking his ears, I would pull lightly up and back for an adult, whereas children, it's down. So up and back, I would insert the otoscope into the ear canal, where I would hopefully see a pink ear canal, which would indicate healthy or skin colored. If it was red, swollen, could mean infection. If I saw redness or exudate, anything coming out of his ear, that would be concerning. If I could get into his actual ear, I should see a healthy tympanic membrane, which would be white and shiny, or like a pearly gray. And then we'd come over here, do the same thing. He already denied any tenderness from the top to the bottom in his mastoid process. Again, it's up and back. We would look into the ear. Hopefully we'd see skin-colored or pink ear canals and a shiny white or pearly gray tympanic membrane. He's not complaining of any problems. I'm not noticing excessive wax in either ear. So essentially normal exam for his ears. And while we're on the ears, I'm just going to cover one. Can you hear that?
Yes.
Can you hear that?
Yes.
Quick auditory test. He heard both sounds. And back to our inspection part, I can tell you right now his chest is not barreled, and he's symmetrical from his shoulders down. Now we're going to use a pen light if I had one, so I'll use a flashlight instead. We're going to check his eyes. So naturally you would want to maybe make it a little darker, and we're going to check his pupils. So you come in from the side and look, focus on something here, and we're going to come in slow. So his pupil constricted and went from, let's say, a 3 to a 1 in size, which is normal. Then we come under. You don't want to constrict the other one too soon. And come in. Same thing with that one, round reactive to light. Now we're going to turn the light back on and assess for accommodation. So focus on one object. We're going to wait and see. So his pupils came back completely normal. And we're going to check his ocular eye movements. So we're going to start at the midline and do the 6 cardinal directions of eyes, or the vision. So we start in the midline, follow with your eyes only. We're looking for nystagmus or extraocular movements, which he is negative for so far. And then we're going to go right into the center. So he's negative for nystagmus, which could be a slew of things. It could mean intoxication, it could be genetic, it could mean an underlying disease like multiple sclerosis. But he's negative for that. And when I brought it in, his pupils reacted and crossed completely normal. So he would be PERLA, which is pupils equal, round and reactive to light and accommodation. So his exam for his eyes were completely normal. So we've done this. We're going to now assess his mouth. And we have a tongue depressor, so I'm going to have you open your mouth. First off, we're going to look at mucous membranes, which are pink. I don't see any noted areas of redness, swelling, or infection. I do note poor dentation, a chip in the front tooth, and he had told me there's a tooth that is broken in his right side, which I can see when I look, but it doesn't look inflamed, but it should be assessed. When's the last time you went to the dentist?
Been a little while.
Okay. Are you up to date with your eye exams?
Yes.
When's the last time you had a physical?
It's been a while.
How long is a while?
3 to 5 years.
So non-compliant. I'm going to have you open your mouth again. So we're going to assess his tongue, which is pink, midline symmetric. I don't notice any puffiness, redness. So example, that would be a sign of pernicious anemia. I'm going to have you lift your tongue up. All right. Completely clear of lesions. Still midline symmetrical. Put your tongue down. Tongue down. Stick your tongue out. Now move it side to side. Okay. Hypoglossal nerve intact. I'm going to place this on your tongue. Okay. So I'm going to look down his throat. Pharynx is pink. No redness, no exudate. And his uvula, from what I can tell right now, is centered, midline symmetric. I'm going to have you say ah.
Ah.
And then we're going to assess your gag reflex really quick. Okay. So gag reflex is important, and the ah because it affects the uvula. His uvula went up symmetrically, it's midline, and that means that his cranial nerves 9 and 10 are essentially intact, which is important for swallowing. Do you have any issues with swallowing?
No.
Okay. So essentially normal exam besides the dental aspect this far. And then we're just gonna look in the nose quickly. So I'm just gonna look, if I had an actual otoscope, it would be better. I would look in his nostrils for polyps, lesions, abnormalities, deviations. I don't see anything. Have you noticed any stuffiness or issues?
No.
Okay. Has your sense of smell changed at all?
No.
How about your sense of taste?
No.
So sense of smell and sense of taste, those are cranial nerve assessment, central nervous. Breathe normal. Breathe normal. Quick way to check for symmetrical breathing. So we've now checked scalp, his skin, perfect. We're gonna move down to the neck. I'm just gonna have you lift up. So we'll assess his trachea. Normal, midline, no deviations, no noticeable goiter, no noticeable abnormalities, a little bit of razor burn. Other than that, no lesions, no skin issues. When you pinch his skin, it tenses and goes right back down. So he's got normal skin turgor, which indicates good hydration. So put your head forward again. So now we're going to check his thyroid, which you palpate from the back. So once you locate, so you shouldn't be able to feel a thyroid. So you want to do that and then have him swallow. So non-palpable, negative for masses and nodules on the thyroid. Okay, and then while we're here, we can check his carotids, which you only do one at a time so you don't occlude them and cause them to faint. So you want to check that with your fingers. Want to make sure that they're symmetrical, easily palpable, not bounding, and a regular rhythm and rate. Okay, easily palpable on that side. Easily palpable on this side. Symmetric. I'll check his carotid bruits once I have him laying down. So we've now done the basic inspection and palpation of his neck, which was normal. So as we're coming down, shrug up against, okay. And then I'm going to have you turn your head this way. And the other way. Be faster, please. Forward. All the way back. Okay, and then side to side. And any pain, discomfort, loss of vision?
No.
Okay, do you ever have loss of vision, visual floaters, auras?
No.
Do you get headaches?
No.
Do you have any pain in your neck or muscle area in the shoulders?
No.
Okay, so we've now checked his range of motion of his neck, but also his accessory muscle by doing that, and his rotation of his neck, normal. So now we're here, we're at the shoulders, so we'll do his arms and his hands, and then we'll move here, do his auscultations, and then we'll have him lay down. So here we are with shoulders. We'll do some range of motion after we do his inspection. So just from looking, his skin is healthy, not dry. There's old scarring here. Tenting, completely normal, indicates good hydration. I don't notice any darkening or abnormalities whatsoever. Hands are pink and normal. Fingernails, have you hold your hands out like that. And just hold them out. No drifting. That's another neurological assessment. Fingernails are normal, no clubbing, no ridging. We're going to check his capillary refill, which at best under 3 seconds, but you usually want them under 2. You can put your hand down. I don't see any noted nodules or swelling in his joints. Okay, so now while I have his hand, any pain when I palpate these joints? Do you ever have issues with inflammation, redness, swelling in any of these joints? Okay. No nodes. Again, hands look normal. I'm going to bring that hand back up. So before I check this hand, I'm just going to have you push down on my hands. Okay? Push up. Grip, both hands. So his strength is 5 out of 5. Symmetrical, his grip is 5 out of 5. Okay, and you put that hand down. Any pain when I do this?
No.
Pain when I palpate this? Any pain here?
No.
Pain here? Do you ever have any lymph node issues in your armpits?
No.
Okay. And any pain here? Any lymph nodes? Have you noticed any swelling?
No.
Okay, turn your head this way. Same thing here. So lymph nodes can be found all the way here, most notably here when there's infection or inflammation, and then in the clavicle, so no swelling, no pain. So we're good there. We've done the basic examination here. So pulse-wise, we'll have him turn his hands that way. We want to check his radial pulse. Pulses should be 3+, easily palpable, non-occluded, not easy to obliterate or occlude. Radial pulse is right above the notch by the thumb, and you want to check it bilaterally, make sure they're even, which his are, which is perfect. And another exam that we did on the other examination, I don't have a hammer, but you could take your stethoscope, is to assess his deep tendon reflexes, which you would hit right about here on both hands. You want to make sure they're symmetric. Deep tendon reflexes assess the central nervous system again, spinal cord injuries, diseases, lesions. They should be symmetric and normal, not hypoactive or hyperreactive. So the brachioradialis tendon reflexes, the pulse. So we know this from his other exam, normal. And then as we're completing his assessment here, we then come up to his elbow. And I'm going to have you put your hand back out like this. And I want you to make a muscle. Okay? So him making a muscle is checking his range of motion for his elbow. Do that with that one, please. Any pain?
No.
So I didn't hear any crepitus or pain with this evaluation. You can put this one down. So him making a muscle allows you to find the tendon a lot easier. So then you would ask him to relax. So once you find the tendon, the bicep tendon here, you could cover it with your hands and you would take your stethoscope or hammer. And we know from his last exam that he was symmetrical on all tendon reflexes. So you tap here, you wait for the reflex. And then again, you would have him take his arm, which is a good way for ROM, and have him tighten, which would then find his tricep tendon, another deep tendon reflex. Now relax and support the weight for him. Relax. And you would take the hammer or the stethoscope right above here. Make sure it's equal and reactive with that side. And again, ROM for the shoulders, the elbow. We know that his hands, there's no issues here. Take both of your wrists, flex them up and down. Any pain or discomfort? Take them, make a fist, and then just rotate. Any pain? Okay.
No.
So his upper extremity is essentially normal. We'll just do an ROM of the shoulders, which we know his strength is normal. Bring your arm up and down. Any pain?
No.
Okay. So now we can go to his the auscultation of his heart sounds and respiratory, and then we'll have him lay down. So when auscultating his heart sounds, you want to, of course, if you had a gown on, it'd be easier because I could open it up. So the auscultation of the heart sounds, he has no hypertension or heart problems in his history. You find the clavicle, and then you want to go to the second intercostal space. This is the aortic. This is an S2, and this is a dub sound. So you auscultate this with the diaphragm first. Listen for at least 5 seconds. And then move over to the pulmonic, which is second intercostal on the left side. And then the third intercostal is Erb's point. It's not a heart sound, but it's a halfway marker. So then you want to go to tricuspid, which is actually fourth intercostal, but more in between fourth and fifth over the xiphoid process. So tricuspid. And then you want to go mitral, which is full 5 intercostal, but it's midclavicular, which is where you would listen for an apical pulse because it's the maximum pulse of heart rates. You would do that with the bell of the stethoscope and listen for a full minute for the most accurate heart rate. You would then do the same examination again with the bell, not the diaphragm. So while we're already here and doing this, we're going to do his respiratory sounds. Are you short of breath at all?
No.
Any asthma?
No.
COPD?
No.
Okay. So starting for his respirations, you want to find the apex of both lungs, which is above the clavicle. Again, shirt not being there would be easier. So you go above the apex, take a breath. You want to make sure you do it symmetrically. Take a breath. Okay, so then you want to move down, almost like the heart sounds. You want to find second intercostal. Breathe. Okay, again. Then you want to go down to the fourth. Breathe. And you want to go from side to side to make sure they're equal. We're listening for abnormal breath sounds. and then you could follow it all the way down the shape of the lungs, and then you want to go to the 6th, breathe, and then breathe. So no abnormal breath sounds, not distant, there's no crackles, wheezes, rhonchi, anything in the front aspect from the that's anterior, posterior, same thing. You want the apex of the lung, which is above the scapula in the back. So breath, and we know from the exam we did earlier that his breath sounds were fine. So this is C7 to T3. You would listen again, breath, 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 breath. Okay, and then you go down T3 to T10, and this assesses the upper and lower lobes. Okay, and upper and lower lobes are in the back, and the upper, middle, and lower lobes are in the front. The right lung has 3 lobes, left lobe only has 2, but his breath sounds are completely normal. His shape and expansion, perfectly normal, no excessive use of accessory muscles. I'm not noting any wheezing, shortness of breath while I'm talking to him or on examination. So we've now completed his top of his examination. I'm going to have you go to the other side of the bed quickly. And so we can do his abdominal examination. Put your head on the pillow. As well as, now that he's laying down at a 45-degree angle or lower, we can check his carotids for bruits. So you would then switch to the bell of the stethoscope. And I would ask him to lift his head slightly and hold your breath. Let go. Hold your breath. Let go. And turn your head to the side. No JVD distension. Turn your head to the other side. No JVD distension. Perfect. So negative for JVD is an assessment for heart failure or excess fluid when you lay down. Are you ever short of breath when you lay down?
No.
Okay. Carotids, no bruits. So bruits are defects in the arterial wall. Could be plaquing, could be, there was plaques, but it puts him at risk for an aneurysm. He's negative for bruits. So now we've now completed his neck examination. So we know that he's normal. He's not short of breath when he lays down. We've done his heart, and there were no murmurs, no valves, no rubs, no clicks. He has no history of that. He has a family history of heart problems, but he himself, as far as we know, does not. So now inspection would be the next part with the abdomen. The shirt on kind of adheres that a little bit. So we would be looking for if his stomach was flat or protuberant or bloated, distended. He's flat from what I can tell. We'd be looking at his umbilicus for any outie, any abnormalities, skin, fungus, moles, hair distribution along his chest and his stomach. And we can't do that, so we're going to assume it's normal. We would be able to see a aortic percussion better if he did not have a shirt on, but we shouldn't be seeing that anyways unless he was very skinny, which he's not, because we know from his vital signs that his BMI is around 26 because he's 190 pounds, he's 5'11". So we're going to go into the examination, which kind of flips from the original. It's auscultate before palpate and percussion, whereas before auscultate was last. So with bowel sounds, you need to have a watch or have a clock or something to time yourself. I'm not going to do it, but what we would do is each quadrant needs a full minute, and if there's no bowel sounds, it needs 5 minutes. And it's done with the diaphragm of the stethoscope on bare skin. So you start with right lower quadrant, and you would listen for a full minute. You'd listen for bowel sounds, 5 to 30 are normal within a minute. And we know from our last examination that he had completely normal bowel sounds. So you go clockwise, you go right lower, right upper, left lower. So once that's assessed and normal, and any bowel changes, bowel movement issues,
No.
do you go regularly?
Yes.
And any issues with urination?
No.
Hesitancy, frequency? Have you noticed any changes at all?
No.
Any changes in appetite, weight loss?
No.
Okay. So then once you do that, you percuss, which we did prior. Belly button, you start right lower. You do a light tap. You want to hear tympany, which just resonates over the gas that should be there. You should not hear dullness in this area. You should not hear dullness over the liver, the spleen, and you'd hear resonance over lungs. Any dullness in this cavity could indicate fluid, which ascites or other buildup obstructions in the stomach, which he does not have. So once you percuss and all sounds are equal and there's nothing abnormal, you would then palpate lightly, 2 centimeters. This assesses for pain. So any pain here?
No.
Any pain here?
No.
Any pain here?
No.
Any pain here? No. So 2 centimeters in, so then you do a deeper one, which is more to check the intestines and organs for abnormalities, and you want to make sure you check the liver and the spleen, just to make sure you can't feel them, because you shouldn't. So the light one is for pain, and he said no in his face. There was no guarding, no rigidity. He didn't, there was no indication that there was pain. So he goes a little bit deeper. Any pain here?
No.
Everything feels soft and normal. I don't feel any notes of constipation, any swelling or obstructions. And then you want to kind of give the liver a once over. I don't feel that. Go over to the spleen, which is more up here. So there'd be like no hepatosplenomegaly, which would be normal. A little bit of liver edge is okay, but normally you don't want to feel it. And then while we're here, we could just go back here for his flank, and we'll check that again. Any flank pain?
No.
Flank pain or CVA would be an indication of kidney inflammation, kidney stones. Do you have any history of kidney stones or urinary issues?
No.
So what we could do next is his arteries, which you would flip the bell, and you would find the umbilicus. You'd find the lower portion of this first line of muscles here. So that would be his aorta. Again, bruits, just like the carotid. You would listen for any whooshing or sounds that there is destruction of the artery. So you're at the aorta, you don't want to push too hard. Then you just move over to the right, which would be his renal artery, assessing for bruits. And again, you want to go to the side. Okay. Then you want to go down to the iliac, which is below the umbilicus. You would assess the left. And then you want to assess the right. And then you want to check his femoral, which we can't because he has thick sweatpants on. Femoral's in the groin. Again, you're looking for bruits. And he's opted to leave his socks on for the exam because he didn't want his feet to be recorded, which is fine. So femoral, we're going to assume no bruits because we're not going to pull his pants down and check his groin. No bruits in his arteries here. His abdominal exam was essentially normal. So I'm just going to have you sit up a little bit. Okay, go ahead. Sit back down. Shirt off would be better, but from what I can tell, no hernias, no visible abnormalities or distension. So now we can come down here to his legs, and we'll assess just from visual, his skin. There's a healing scab here. His skin looks a little bit dry, but it looks healthy. Skin turgor healthy. His tenting, just like up here, which indicates good hydration. I'm not seeing any swelling or redness. His skin temperature feels good. I don't feel any areas of warmth. I don't see any redness. I'm not palpating any masses or lumps. Any pain in your legs?
No.
There's no edema whatsoever. If I could see his feet, I would probably comment on his toenails. If they looked healthy, I could do his capillary refill, which I cannot do. And then go to the next line, same thing. Any pain here?
No.
Any pain in your thighs, which
No.
I can't see, but I can palpate. And again, no edema. Do you ever have issues with numbness or cold?
No.
If you didn't have socks on, I could check for numbness with a monofilament, and I'd be able to see if his feet were cyanotic at all, but he is saying he doesn't have an issue with that, and it's not in his history. So, brief exam with the inspection and a little bit of palpation. So we can assess his popliteal. You can just rest it. So popliteal is behind the knee, and it's another pulse. So you want to make sure it's easily palpable. 3+ is normal. That it's not bounding, but it's regular. If there were any kind of issues, it could indicate there's an occlusion or some other problem elsewhere. And when you get to the lower extremities, you worry about venous changes or occlusions with varicose veins. But his pulse is easily palpable. We're going to check this one. Loosen your leg. Okay. Same thing here. So that's popliteal. And on a basic examination, it's easy to check. There's no cysts, no masses that I can feel. He denied pain in his knees, so we're going to come down here, ankles, and his tibial pulse is here, which you can check, and you can make sure they're equal. Another sign of good blood flow, no constrictions, no occlusions. And you can palpate that right here on the internal ankle, 2 fingers. Don't push too hard, but push hard enough. So his pulses thus far are 3+. His dorsalis pedis, almost done. And so his pedal pulses, we could assess bilaterally between the big and the middle toe, right about here. Make sure that they're present, easily palpable, not occluded, which is a little difficult with socks on, but it's okay. We can't comment on his toe colors, so we're going to check his extension flexion, ROM. So flex your feet up, dorsal flexion is good, bring them down. All right, plantar is good. I'm going to have you push, and then try to bring up. Okay, and no numbness or issues with your feet?
No.
No pain when I pinch your joints?
No.
Ever had any issues with redness, swelling, abnormalities in your joints?
No.
Okay, I would check his heels. I would check, make sure there was no ulcers, no wounds. He's not diabetic, as far as we know. And now we can just do a quick ROM testing before we sit him up to finish off the tendons and the balance. So I'm going to have you pull this knee up to your body. Any pain?
No.
So hip ROM and knee ROM. Okay. And then I'm going to have you bring your leg up. Any pain?
No.
Okay. Straight leg raise negative, which is an assessment for sciatica and also the hips. And then we can just check a quick internal rotation. Any pain when I do that? Which is a good way to check the hip. Any pain with that? Okay. Loosen? Nope, loosen. And then, any pain with that?
No.
Any pain with that?
No.
So hip, ROM, rotation, good. No pain in the knees, he's able to extend. Negative raise, so that indicates not any issues with the sciatic right now. Do you ever have sciatica issues?
No.
Okay. And we know that his muscle strength thus far is 5x5 in his feet, his arms, his hands, his grip, his shoulders. So we're good on the lower extremities. I'm going to have you sit up and put your feet over there. Okay. So just to finish off our exam, again, we don't have a hammer, so we need our patient to make sure their feet are relaxed. Let them droop, hang down. Hang your feet down. No, down, like have them pointing down. Completely let go of your muscles. So that's important because you're not going to get a reflex. So when we come, we want to make sure we can check the patellar deep tendon reflex. If I had a hammer, you could use your stethoscope. You got to make sure you find it. You also have to make sure that they're relaxed or it's not going to do anything. The tendons right below the knee. You'd wait for a reflex. Make sure they're relaxed and that it's symmetric. Okay. And then you could check the Achilles. They really need to make sure their feet are relaxed. Okay. He's not super relaxed, which makes it a little bit difficult. He struggles with this. There's a slight reaction, but his foot is tense. So to finish off the examination, we can't really comment conclusively on the Achilles because he has a tough time relaxing his feet all the way, but from what I could get, they were symmetric. So we're going to finish off with a quick balance exam. Do you have any issues with dizziness, vertigo?
No.
Okay, have you stand up. So we're going to do the Romberg. Have your feet together. Close your eyes. And we're going to note any swaying or imbalance with his eyes closed and for how long. We'll give him 10 seconds. A little bit of swaying. Okay. So a little bit of swaying, but nothing too bad. I'm going to have you walk heel to toe in a straight line, and when you come back, walk on your tippy toes. Okay. Straight. No imbalance. Dorsiflexion weakness. No, you need to walk on your toes. Walk on your toes that way, and then walk on your heels back. So he's being kind of lazy. So normal dorsiflexion, normal heel. So no abnormalities in weakness with his feet on balance, dorsiflexion, weakness fine, heels fine, heel to toe was fine. That assesses balance, gait, ataxia. Police use it for intoxication screenings. His Romberg was essentially negative, a little bit of swaying, but he didn't lose his balance at all. And that concludes his assessment, and I'll post the even longer one that we did the full assessment on. But essentially, all of his findings were normal except for his dentation, which is what we're going to focus on with his education. In real life, I would wash my hands, I would take my gloves off, wash my hands again. I would ensure that the room is safe. If he's in a bed rails are up, the room is decluttered, his call light is next to him, that he's okay, recheck his vitals like we did at the beginning, make sure he's comfortable, he's not in pain, and that he has everything that he needs before exiting the room. I would say goodbye to him. You want to make sure to empathize and be sympathetic with your patients while you're doing exams and know any kind of tenderness or abnormalities. He's healthy, so that's easy. And that concludes our second round of our assessment for the day.